All right, welcome everybody. Thank you so much for attending the New Technology Breakout session. I am Bethany Slater from the University of Chicago and the chair of the New Technology Committee. And today we have 4 abstracts that were selected to be presented in this session. And then the second half will be regarding a panel on 3D bioprinting. We have a great group of panelists to teach you all about 3D printing. So we'll get started with the first abstract entitled "The Novel Use of Rare Earth Magnets for the Extraction of Metallic Soft Tissue Foreign Bodies in Children," presented by Dr. Lukish of Children's National Hospital. And I do not believe he's here. Yeah.
Hey, sorry.
Penetrating metallic foreign body injuries are common in children. Once embedded in the soft tissue, these objects can be challenging and time-consuming to remove, often requiring a large incision and soft tissue destruction to gain access to the foreign body. This procedure often requires fluoroscopy, exposing the child to significant ionizing radiation. The use of magnetic technology to facilitate removal is logical. Neodymium iron boron magnets are powerful rare earth magnets that are commercially available. The magnetic energy density of these magnets are 8 times that of aluminum nickel cobalt magnets and 40 times that of conventional ceramic and iron magnets. The use of these powerful magnets may expedite the retrieval of a metallic soft tissue foreign body. This is a 13-year-old child who suffered a penetrating metal pin injury to her left foot. As you can see, the pin is embedded in the soft tissues between the 4th and 5th metatarsal. There is a healing wound, and the area is tender, but the pin is not palpable on exam. In the operating room, we use fluoroscopy to localize the pin, and we first try and use the magnet to extract the pin without making a skin incision. This has not been successful in our cases. We then place the magnet in a sterile US probe cover and prep the child's foot in normal sterile fashion. Utilizing fluoroscopy, we make a small incision over the area of the foreign body and into the dermal soft tissues. We then place the magnet in close proximity to the foreign body using fluoroscopy. The pin is immediately extracted from the soft tissues, as you see in this video clip, without the need for soft tissue dissection. This next case is that of a 9-year-old who suffered a penetrating pin injury into the heel 3 days prior to this exam. As you see in the x-ray, the pin is in the deep soft tissues over the calcaneus. On exam, the area is erythematous and tender. The pin is not palpable. We are unsuccessful in extracting the pin without a skin incision. However, using fluoroscopy, we make a skin incision in close proximity to the pin and into the dermal soft tissues. Using the magnets, we safely extract the pin without any tissue dissection. Both children recover uneventfully. This is the first report of the use of neodymium iron boron magnets to remove soft tissue metal foreign bodies in children. We found that the use of this technology is efficient, safe, and effective. These rare earth magnets have the potential to reduce the operative time and minimize ionizing radiation exposure. In addition, the use of this technology may also allow for smaller incisions, less dissection, and concomitant tissue injury. This factor may result in reduced pain and potential disability in children. Further development of this technology for intraoperative use is indicated.
Well, this was a great video, very cool idea. I, of course, love magnets and definitely struggled with these cases. So this is open for questions.
Todd Ponsky, Cincinnati. So I would say that this could be one of the more groundbreaking papers we've seen because I hate this procedure. Okay, you go in, I end up using more fluoro than you're allowed, and I dig 100 times and I cannot find it. The question is, I don't believe it. I'm challenging because this is my statement. This is so amazing, and I think this is going to change the entire way everyone does it. So I'm joking when I say that, but have you had cases where it didn't work, that you didn't show us? Because those looked like great cases where it just sprung out. And the second question is, can't you just add like 10 more magnets so if it doesn't come out eventually it'll just shoot right out through the patient, or is that crazy?
Well, Dr. Ponsky, thank you for those questions. Great questions. I think in regards to the first one, I would say that for these two patients, for this procedure, these two patients were the only two patients that we considered using the neodymium magnets to facilitate the extraction. And then for your second question, I think, your second question, pardon me, what was it again? Oh, right. So I think in regards to that, if you were to increase the magnetic strength of the instrument you're using, I think there is some concern for collateral damage when you're pulling out and, extracting the metallic, foreign body. And I think there is some serious concern for that. And, looking forward, I think, if you're considering the use of this technology, I think, the only metallic soft tissue foreign bodies that you should consider extracting using this are ones that, have a very clean entry wound. Because if you were to, use it on maybe a, unusual object, it might, lead to that collateral damage.
Hi, I'm Melissa Seff from Omaha. Just a quick question. Did you close those incisions and how did you close them?
To be honest, I was not there for either of these procedures, but I did put together the rest of this presentation, but it was not there for these procedures.
Yeah, this is indeed my son. I learned so much from my young kids, but when we came home one night saying I had to go back to the OR to pull this out about 2 years ago, he and his brother said, "Dad, why don't you just use a magnet?" And I thought about it on the way there, and I said, it actually makes sense. So I had to give him this project and say, make this happen for me. To answer your question, it's a good question. Ideally, you would try and extract these without making a skin incision, because that's the problem. These wounds get infected. We did close these, but we, like most of us, we close them with simple sutures and close it very loosely, and we tell the folks that this is going to get infected. But I think in the paper that John has written on the subject, he's really done a lot of research with different magnets that have greater ferrodensity, and I think our goal, I think where this project will inevitably go is utilizing a stronger magnet so we can do it without having to make a skin incision or make a tiny little hole. Tiny little hole. We did and we had it. So if I want to do it, I have to go get out. Yeah, you do, because you just got to go through that whole board business.
Can I ask a question? Oops, sorry.
Thank you.
Thank you. All right, our next presentation deals with another difficult issue that we all deal with, entitled A Precision Design Gastrostomy Button Securement Device, presented by Dr. Stevens from Children's Hospital, Colorado.
Good afternoon, everyone. I brought a sample of our design here for the panelists to look at while I talk, so you guys can pass that around. Thank you for the opportunity to present our work. Let's see if we can get this in the right mode. My mouse is not working, so.
He's working for me.
Okay, thank you. Perfect. Thank you for the opportunity to present our work. These are our disclosures. Surgical gastrostomy is the third most common non-cardiac inpatient surgical procedure performed in children in the U.S. Gastrostomy buttons, or G buttons, are commonly placed in children to facilitate weight gain, correct nutritional deficiencies, and provide hydration and/or medication delivery for children. However, the problem is that to date, there is no product on the market to reliably secure these G buttons. At our institution, parents are taught to dress the site with the so-called tic-tac-toe dressing, which consists of a split 2x2 gauze and 4 strips of tape. Application of this dressing is both time-consuming for the parents and uncomfortable for the child. And the G button remains poorly secured, allowing for movement in the tract, which delays wound healing and leads to a variety of tract-related complications, including granulation tissue with leakage, peristomal infections, as well as accidental dislodgement, which can be particularly problematic as this often requires a radiologic study to confirm replacement in the stomach. We viewed this universal problem as an opportunity for innovation. In 2016, a pediatric surgeon and a small group of graduate engineering students created a team. Together, we outlined the problem, created a list of design requirements, and began to iterate on a variety of device designs. Our principal design goal was to develop a G-button securement device that could both accommodate human-related forces while limiting external forces. The team started with over 400 design ideas that were discussed and iterated upon to various degrees. From these design ideas, several early prototypes were developed. The first 2 prototypes were studied in a small clinical trial in which 80% of caregivers reported satisfaction with the design. However, 90% reported that the device was too large and that there was difficulty attaching and detaching the extension feeding tubing. Building on this feedback, a third prototype was created that was smaller and included the addition of both a removable and reusable lid, as well as pre-cut sterile gauze. 4th and 5th generation prototypes included the addition of edge grippers to facilitate attachment and detachment of the extension feeding tubing. Finally, in 2020, the design was finalized with the addition of a child-proof hinge between the lid and the base layer. I'd like to show a quick video that highlights our final device design.
The Button Huggy is a precision-engineered medical device that is designed to simplify care for your child's gastrostomy button and reduce gastrostomy-related complications. It is composed of 3 layers: a disposable base layer, an absorbent layer, and a reusable lid. The base layer's inner structure is designed to hug the gastrostomy button, minimize movement, and stabilize the button when inserting or removing the extension tubing. The middle layer is an absorbent gauze pad that wraps around the stem of the gastrostomy button. The top layer is a washable, reusable lid with 3 parallel slits, providing ventilation and flexibility, which improves comfort while wearing the Button Huggy. The lid snaps onto the base layer, creating a child-proof hinge, which allows the lid to rotate downward and snap onto the front end of the base layer. To apply the Button Huggy, wash your hands with soap and water. Then, make sure the skin around the gastrostomy button is clean and dry. Open the feeding port. Remove the adhesive backing. Lower the Button Huggy down over the gastrostomy button. Gently press down on the adhesive. Slide the gauze under and around the stem of the gastrostomy button. Close the lid and reinsert the tab into the feeding port. For more information, visit buttonhuggy.com.
An intuitive gastrostomy button securement device was created to simplify daily gauze replacement, reduce tract-related complications, prevent accidental dislodgement, and lower the cost of care. A 200-patient multi-center randomized controlled trial comparing our securement device to standard of care dressing will begin in June of 2022. I'd like to thank all of the contributing authors who helped with this project, as well as Children's Hospital Colorado and the Department of Engineering. And I'll take any questions now.
Outstanding talk. Really cool. Hey, what's the cost of the device? What is your markup now?
We have not taken the device to market yet. We'll plan to do that at the time of the clinical trial or after the clinical trial.
How often will the little piece of inserted gauze need to be replaced?
So that's the one. The cool thing about this is that of those 3 layers, the gauze is the only thing that needs to be changed. We'll plan to give, when we send the kits out for the trial, we're going to plan to send 120 to 130 pieces of gauze with the devices. And so we'll instruct the parents or caregivers to change it once daily, but they can also change it as needed or if it gets soiled more frequently than that.
That gauze is part of your design as well?
Correct.
Okay, excellent.
It's really beautifully presented, and the video is really nicely done. What are your endpoints in their randomized trial?
Yeah, that's a great question. So we plan to evaluate the progression of the trial at 4, 8, and 12 weeks, and we'll do that by calling caregivers or having them come into clinic. And we have a series of questions that we'll ask the caregivers that will span all the way from their overall satisfaction with the device design, how often they're having to change the gauze pad, whether they feel the adhesive is sticky enough or too sticky, all the way to our complications. So we'll look at how often they called the surgical clinic or how often they came to the ED within that time period, as well as whether there were any incidences of granulation tissue, any infections, or any dislodgement episodes. We also plan to take pictures at 4, 8, and 12 weeks as well, so we can mark and track those complications if we have them. And then we'll compare that to our control group.
Yeah, I'm just bringing up this question because I think this is a great area for thinking about the parents. We always think about outcomes in the kids, but this is an outcome for the parents because the burden of this all lies on the parents. So I think just looking at things like productivity, how much time they have to take care of the gastrostomy tube, have they missed any work days? I mean, all of these things that we're not thinking about, I think this is a prime study for starting to think about these questions.
That's a great
Very
point.
nicely done.
Thank you.
Real quick, first of all, super congratulations. Can you explain to me how was this a clinician idea? And then how do the clinicians have time to move forward? Is there a process that you have funding for this? I think it's really hard for clinicians to actually get a product like this done. I don't understand how you do it.
So I have to give full credit to Dr. Steve Moulton, who is in the audience. He's the PI for this study and who came up with this entire design.
How does it go through?
And has been working on it for several years. So he came up with the idea because he was seeing so many of these complications in clinic and at the hospital. And then started by obtaining grant funding through some small grants at the University of Colorado, putting together the team of engineers. And then we've been working since 2016 to obtain additional funding, securing the team that will do the production, the sterilization, and that's taken several years to do that.
So it's a one-off. You don't have a system to keep doing these over and over again, to take clinician ideas and take them to market, to take them to a product. Just the opposite. Oh, okay. Congrats. Great job.
Thank you.
Congratulations, Mike Leanwan from Kalamazoo, Michigan. I also work with engineers in my university, and like yourself, I have many projects in the pipeline, and it is very difficult to do, but it's doable. For this particular project, I'm concerned, and I want to ask if you're going to be specifically looking as compared to controls. I'm concerned, so I don't have my parents do anything with G buttons. So in this case, this represents increased work for them, not decreased work for them. I would be concerned specifically of some of the things you mentioned by having that on there all the time, fungal infections, by locking in moisture and such. And granulation tissue, I'd be really interested in knowing if you have less compared to your other techniques. So are you using controls where you're not using this to compare granulation tissue?
The control will be the tic-tac-toe dressing. So they'll either be randomized to get the device placed or they'll have that dressing placed.
So it's, I mean, I'd be interested in knowing whether no dressing at all.
Yeah, that's a great point.
Because I do have a fair amount of granulation tissue issues, and I'm wondering if that causes granulation tissue. But on the other hand, I don't have the issues with rashes and fungus and other things. Plus, you don't get it pushing in any one area.
Right.
So it allows it to rotate in such a way that the skin is healthier.
Well, and earlier today, I was just talking to some other surgeons who don't put any dressing at all, exactly like you said. And so I think it will be interesting to see what we learn from the trial as far as our complications and what we see with the device and then what we see with the controls. And then hopefully we can do another trial where we compare it to no dressing at all and then compare our results.
Lastly, I did love your video. Was that made by the university or did you hire an outside company to do that?
The university made that. Thank you, guys. Appreciate it.
The next abstract is entitled A Novel Instrumented Compression Bracing System to Treat Pectus Carinatum, presented by Dr. Voulez Dietbille from, sorry if I butchered that, from the University Children's Hospital of Basel in Switzerland.
So, hi, my name is Raphael Wüdibille. I'm from Switzerland. I also there the name is difficult to pronounce. And I'm happy to present our project about a novel instrumented compression bracing system to treat patients with Pectus carinatum. So I have nothing to disclose. So Pectus carinatum, as you all know, is an outward bowing of the chest, and in the literature is still the second most common chest wall deformity. In larger clinics, we see even more patients with Pectus carinatum than Pectus excavatum nowadays. The prevalence is even higher than 1 in 2,000 live birth, and it has a similar male to female ratio like Pectus excavatum, and it typically shows a progression of the disease during the growth spurt in adolescence, like Pectus excavatum. So really briefly, the treatment consists either of pure observation, which is typically done in children below the age of 10 years, or bracing, or different surgical techniques, either open surgery by the ravage or modified ravage technique, where the affected cartilages are resected and an anterior osteotomy is made, or the reverse Nuss or Abramson technique, where a Nuss bar is placed in front of the sternum and the sternum is pulled back and the bar is secured at the lateral chest wall. So bracing is considered by most pediatric surgeons, there was a survey in Canada, as first-line treatment in patients older than 10 years of age, as it has a very low complication rate, mostly consisting of either smaller skin irritations or back pain. But bracing outcomes are really not well documented in the literature. So the first study that I could find about bracing was published in 1977, and at that time they used plaster casts. And since then, different types of braces have been produced and are used among different hospitals in the world. And even in Switzerland, where we have less than 9 million inhabitants, every children's hospital uses a different brace. So this is the brace we've been using for many years. It's a dynamic compression brace. It's an aluminum brace produced in Argentina. There is a nice study published in 2008 that describes this brace. And there's a device that can plug to the brace that measures actually the pressure. And what we've been doing is that when we saw the patient for the first time in clinic, we measured the pressure of initial treatment. So that is the pressure to achieve like a normal configuration of the chest. And then we adjusted the brace that there is a pressure of the brace against the anterior chest wall between 2 and 3 pounds per square inch or PSI. And the aim of this project that I'm presenting now was to produce something or a tool that is able to continuously monitor the compression pressure. So this is the current prototype that our engineers or our colleagues from the ETH of Zurich built. So you can see on the right-hand side a loading cell, and what this loading cell does, it measures actually the pressure. It does the same, it measures the pressure of the brace against the chest wall, and this loading cell is connected to an electronic unit, and this electronic unit is then connected to a smartphone, and this is the readout of our prototype. So you see in this patient, the pressure was 2.3 psi, so was within our desired range between 2 and 3 psi. So this is the prototype feedback that we can give either to the healthcare providers or to the patients and their parents. And of course, when we validated or calibrated our pressure, our load cell, it showed exactly the same values as the commercial pressure measuring device. So the goal of this instrumented compression bracing is to have something that continuously monitors pressure, so not only once every few months when we see the patient in an outpatient clinic and he's standing upright in front of a physician, but in all activities during daily life, so when the patient is sleeping, ambulating, watching TV or whatever. And we want to give the patient and or their parents the ability to adjust the brace themselves, not only in clinic. And our hypothesis is that we hereby will be able to avoid pressures that are over 3 or below 2 psi, so we try to avoid over or under treatment, hereby try to reduce complications, improve adherence to the therapy of the patients, and finally reduce the number of healthcare visits and costs. So this is the currently ongoing development of our preliminary product. So we try to miniaturize now the sensor we try to build a sensor which is not only compatible to our brace, but will be compatible to all different kind of braces. We'll add another second sensor, which will be a temperature sensor. So the second sensor will sense how often and how long the patient is actually wearing the brace. And of course, we will avoid any direct contact or either of the electronic unit or the sensors to the skin. We'll also miniaturize the electronic unit itself. And at the moment, the electronic unit of this prototype needs to be switched on and off manually. But in the future, it should be done it should switch on whenever the patient closes the brace. And then the data from the electronic unit will be transmitted to the phone or the tablet to the patient via Bluetooth transmission. So of course, we also intend to measure treatment progression. And to compare our instrumented brace to the conventional brace. But unfortunately, at the moment, there is, at least in our eyes, no good tool available to assess severity of disease and also to assess treatment progression. So some healthcare providers, they use different kind of external measurements, as you can see here, but these are often imprecise or provider dependent. Others do repeated imaging. We only do imaging in those patients that we prepare for surgery. And if you have to do repeated MRI imaging, it's costly, and probably not every institution has it readily available. And if you do repeated X-rays or CT scans, then you radiate the patient and increase his lifetime risk for a later malignancy. So there is no easy and exact and cheap tool to assess the severity of the disease, and therefore in a second project we are also with our colleagues of the ETH of Zurich, we are developing an optical system using a from skin to skeleton principle. So this is from a scoliosis project where it's currently developed. The computer assesses a 3D surface analysis of the skin and combines this with several landmarks, and then the computer calculates the shape, the location, and also the orientation of the underlying bony structures. And we plan to use a similar optical system and to develop it also this from skin to skeleton principle for patients with Pectus carinatum. So I would like to thank my partners at the University Children's Hospital of Basel, which you can see on the left-hand upper side, and especially our collaborators, the engineers at the ETH of Zurich around the group of Professor Bill Taylor at the ETH of Zurich. Thank you very much.
Thank you, very nice work. I just have a concern, and maybe that concern will turn out to be invalid, but you know, we've braced now close to 1,000 patients over 10 years, and probably the most important lesson we learned is that it's not the brace, it's the bracing program. And normally we want to put things in kids' hands, you know, we want to put things in the parents' hands. The problem is this is a really challenging population. A lot of these adolescents are very excited to start the brace, but you know, after a month or two, they lose interest. And we found that what really helps is to bring them back with other kids around. So we have group meetings with, you know, the Pectus patients, and knowing that they're going to come back and see the orthotist and see the surgeon and get an adjustment makes a huge difference. When we used to just prescribe the brace and say, you know, you tighten it yourself and we'll see you in a year, our compliance rate was horrible. And now our compliance rate is close to 80 or 85%. So my concern is you're doing something I think that is very admirable. You want to put it in the patient's hands and decrease visits and so on. But I think it's the program and they actually coming and participating in the program that defines the success of bracing. That's just my bias, and maybe it's not going to prove right, but I'm curious what your experience has been. And by the way, your institution has really led in Europe in this area, and you're to be congratulated on that.
So an idea, maybe a similar idea that we had or that we have in mind, but this is probably in 5 or 6 years. So if we have this this smartphone or tablet application, so what we would like to have is some kind of virtual groups or some kind of, even if the adolescents could like be competitive against each other. So how many dropouts they have, who is better, who is faster in adjusting the brace, so to have them be better adherent to the program. So that was kind of an idea that I had in mind. Yeah.
This is what I was going to say, actually. Forgive me for not remembering exactly who. It might have been Marcelo in Argentina, but this has been done where they've done gamification of this with the teenagers kind of playing against each other with all of their data online. So it has been done, and it, from what I remember from a previous talk, it's worked very well.
Yeah.
Thank you very much. So we'll switch gears just a little bit for the second half of the session, move on to our panel regarding 3D bioprinting. We do have one abstract included that does fit into this topic as well.
All right, well, thank you guys for joining us for this. I'd like to announce our first presenter. It's Dr. Huerto talking to us about Introduction to 3D Modeling and Printing.
Good afternoon. My name is Carlos Huerta. I'm a general surgery resident from the University of Miami. Today we'll be giving a short introduction to three-dimensional modeling and printing applications in pediatric surgery. Over the past few decades, 3D printing has emerged as a promising modality to improve both surgical education and patient outcomes. It's been used for clinical applications since 1999, when the first tissue scaffold was 3D printed and seeded with autologous cells to regenerate bladder tissue in a patient. Over time, integration with imaging data has allowed for 3D generated models to be generated with a level of detail and depth perception that substantially builds upon the information provided by 2D imaging alone. This has been utilized since the early 2000s, particularly for preoperative surgical planning in the realm of congenital cardiac surgery defect repairs. Over time, each of these 3D technology applications continues to expand in their potential. Firstly, in regards to surgical models, 3D generated models can be utilized for both preoperative planning and intraoperative guidance, which are particularly useful for anatomical variants that are rarely encountered in clinical practice, such as this example of a 3D generated model of a pair of omphaloesophagus conjoined twins, which is further detailed in our committee's toolkit. Regarding education, 3D generated models can be utilized both to improve patients' own understanding of their disease processes, as well as improve surgical simulation capacity for all levels of trainees. Finally, this technology can be further utilized to customize medical devices through both tissue scaffolds, which can be used to regenerate hollow viscous organs with emerging research into this field, as well as patient-specific implants. For each of these applications, studies have demonstrated benefits for both patients and surgeons. Surgical models of renal anatomy can be utilized for both preoperative simulation and anatomical mapping of anastomotic sites, which some studies have demonstrated can decrease operative time and blood loss in the realm of pediatric renal transplantation. Surgical simulation models, such as those for laparoscopic pyloromyotomy, have been shown to improve trainees' confidence in performing this procedure in patients for both residents and fellows, given the improved tactile feedback that these models can provide. Finally, through integration with imaging data, 3D printing models can be utilized to improve the patient-specific morphology of implants, such as through customized Nussbaum implants for the correction of Pectus deformities, which some studies have demonstrated can decrease the risk of multiple bar insertion attempts for this procedure compared to standardized Nussbaum implant sizes. Ultimately, as this technology continues to expand and show more potential, we can see a wide variety of benefits at all levels for patients, surgeons, and trainees. With that, I'd like to thank the New Technology Committee for allowing me to present today, particularly Dr. Bethany Slater and Dr. Christine Fink for the opportunity.
Next up is going to be Dr. Wainsick. She is coming to talk to us about the use of 3D bioprinting technology to fabricate pediatric airways. She's from the University of Connecticut. And this is the abstract as a part of this session.
Okay. All right, I think that was a nice introduction to what I'll be talking about today. Just wait until my presentation comes up. Okay, great. Oh, no, the other airway one.
The next
Hopefully they have it.
That the toolkit will be up on the APSA website focused on 3D bioprinting. So thanks to Dr. Slater for helping us get that up and loaded.
Okay, so today I'll be talking about the use of 3D printing technology to fabricate pediatric-sized airways. So the following study is supported by the NIH grant listed below. As an introduction, the field of tissue engineering is focused on the repair, regeneration, or replacement of damaged, diseased lungs, particularly in populations suffering from bronchopulmonary dysplasia, also individuals with cystic fibrosis, and also chronic respiratory disease or congenital defects. So previous approaches have focused on the use of decellularized lung scaffolds that have the resident lung cells removed with detergents. These are then seeded with patient-specific stem cells for use as a potential source of implantable lungs. However, limitations exist with this approach due to damage of the vasculature because of the harsh detergents that are used for that particular approach. So new approaches are warranted to improve the therapeutic options available to these vulnerable populations. So one of those novel approaches for engineering lung tissue is 3D printing technology. This encompasses three main types of the techniques. The first one is fused deposition modeling, stereolithography, and then bioprinting. So they all differ based on the types of materials that are used. And each one of these technologies have been used to create biomimetic tissues and scaffolds that have been derived basically from the skin, heart, liver, and kidney. So as Carlos went over a little bit about bioprinting, it is a technology that utilizes cells embedded in a biological matrix or bioink, and it's used to print complex structures in a layer-by-layer fashion that mimics the microenvironment and ultrastructure of complex tissues. So the benefits of this are high precision and accuracy. You also have the potential to replace animal models and also organ donors. And I think a really great benefit of this is that you can make patient-specific and personalized treatments when you make a model specifically from a CT scan. So that is exactly what I'm going to be going over today. So we're investigating whether or not this technology can be used to fabricate a full-sized, anatomically accurate airway model derived from a pediatric CT scan. So the first part of this is that we created a computer-aided design which basically was taken directly from the CT scan, and using a 3D program called 3D Slicer, it converted it into a 3D model that was able to be recognized with by the printer. So basically it converts this information into a programmable language that you can upload directly to whatever machine that you're printing with. And here is just an example of that same CT image that was converted into a model. So this is a stereolithography-based approach. So here we were using a polymerizable resin material that was UV cross-linked. So in the middle here, we have the airway construct with supports. And then we removed the supports. The supports are basically used to help you print this actual structure, and you cross-link it with the UV light, and then you're able to remove the supports and end up with a nice model that's able to hold its shape. So this is an FDM printed construct using a synthetic plastic. Then we have a stereolithography printed flexible hollow construct. So this just shows the ability to use this technology to print these airway constructs with materials that are becoming more and more similar to the mechanical properties of the lung tissue. So ultimately, our goal is to print these pediatric airways using a bioprinting approach. So instead of the synthetic plastics, we want to move to the soft biological materials. And one way to do this is through a technique called freeform reversible embedding of suspended hydrogels, or FRESH for short. And this is a bioprinting method developed by researchers at Carnegie Mellon University. And basically what it entails is you print directly into this slurry bath of gelatin microparticles. And there's a cross-linker that's added to the bath. So once you print your construct, it's able to hold the shape of your 3D printed model. And then you remove this bath by exposing it to 37 degrees Celsius, and then it melts away, and what you end up is with your construct that you can immediately put into culture. So we just went through some of the fresh optimization, determining the best concentration and also the mixing speed. Microparticle size is really important because it determines the final resolution of your construct. And so the slurry bath has mechanical properties similar to a Bingham plastic, meaning that when you put your nozzle through this material, it's able to reform, which is really important to make sure that your structure doesn't fall apart. So here is an example of a fresh bioprinted hollow alginate tube. So this was our proof of concept, showing that we could use this technique to create a hollow structure, remove the bath, and have it not fall apart or basically fall on itself since it was a soft biological material. This is a bioprinted branch structure that prints. So on the left, you can see it within the support bath, and on the right is after the support bath has been removed and melted away. So we were able to create these high-resolution structures that were able to hold their shape. The next step was to do mechanical characterization of the bioinks that we used just to make sure that the properties were similar to the lung tissue. So here's just the results from us testing out different biological materials such as alginate and nanofibular cellulose. And that was one of the ones that we settled on that had the closest properties to the lung tissue. So we're currently working on scaling this now to a larger format. And we are also testing the viability of lung-derived stem cells embedded within these 3D printed bioinks. And we found that several days post-printing, the viability was about 80 to 90%. So to conclude, 3D printing technology allows for the fabrication of anatomically precise pediatric-sized airways from CT scans. And the potential to use this technology for lung tissue engineering is highly attractive and would significantly further the field. However, limitations still exist related to what is the best material to use for printing these biomimetic lung constructs. And the technology is not quite there yet with the resolution that's needed to obtain or to mimic the alveolar regions of the lung. However, the field is rapidly advancing and new printers and biological materials are constantly being developed, so we may be able to address this in the future. And we will continue to optimize the bioprinted airway construct and then test the use of decellularized human lung tissue embedded with lung-specific stem cells as a potential bioink. So I'd like to thank Dr. Christine Fink for her help and guidance with this project, as well as Joanne Walker, our lab manager, and then medical residents Hala Sena and Anna Menendez, and our collaborators at the University of Vermont, Dr. Daniel Weiss and Dr. Loredana Asarian. Okay, if there are any questions, I can take them at this time.
Kathy Barsness, Children's of San Antonio. Fantastic work.
Thank you.
In particular, the challenge is always the scaffold to support a hollow or aluminal structure. And I, in particular, really like the one from Carnegie Mellon using the microbeads. The gel beads.
The fresh.
What is your resolution? Because your proof of concept looked like it was very thick walled to support. And so what is the tissue thickness that you can get down to but still support within that scaffold? And what is the overall size that you can print at? Because right now you're printing in a very small gel. And is there scalability for that?
Yes, it's a good question.
But amazing work, so thank you very much.
Thank you. So yeah, the resolution all depends on the size of the nozzle that you're printing with. So you can actually get down to a 25 gauge needle, and that will give you a resolution about 100 microns. So, I mean, the technology, it's definitely advancing. I think the stereolithography-based approach, you can actually get better resolution. But with the 3D bioprinting approach, the best you can get down to is 100 microns. For the scalability, Actually, I didn't include it in this presentation, but I'm building a larger format printer because the one that we currently have, you can only print it so high, but the one that I'm actually developing, you can actually print it like as big as you want, basically. So it would be more applicable for like a full-scale organ. Okay.
Thank you very much, Heather.
Thank you.
Okay, next up is Dr. Anthony Tsai, here to talk about the 3D printing of the airway. He is coming to us from Penn State Children's Hospital in Hershey, Pennsylvania.
Hi, everyone. I want to thank the panel for giving us, the opportunity to present the current status of 3D airway printing in literature in pediatric surgery. So pediatric airway obstruction can be led by multiple causes, and it all has to do with the lack of or loss of the innate structure of the airway. So the airway has both the membranous part and the cartilaginous part. And some of these obstruction can be due to a congenital anomaly or acquired anomaly. And two that we'll focus on today is tracheomalacia and tracheoatresia. 3D printing is a technology that's oncoming, and there's lots of application that's been developed for it, and certainly it's very exciting and has a lot of potential applications. One of the most readily available application is pre-procedural planning, and specifically to the airway, there's multiple groups that have attempted to use 3D printing to assist in surgical planning. This is a comprehensive list of different publications that's out there on airway that's assisted by 3D printing. A lot of it, as you can see, has to do with tracheal airway anomalies. This is what some of the 3D printing can help assist in pre-procedural planning. This is a case of tracheal agenesis that's used 3D printing for anatomical understanding of the relationships with different structures, as well as how the eventual therapy can fit within the actual patient model. In terms of airway implantation that's been used, there's also significant number of publications out there in the ENT literature on how this is very helpful. A lot of these are also published on the pathology of tracheomalacia or tracheobronchomalacia. The biggest series comes from University of Michigan, and this is done on severe tracheomalacia cases, as you can see on the right. The picture on the left is a picture of the normal tracheal lumen and on bronchoscopy, and the one on the right is a severe tracheomalacia. Traditional management of this disease typically involves CT scan and endoscopy preoperatively, and treatment depends on the severity of the pathology, and it can be supported treatment using continuous positive pressure therapy, plus or minus tracheostomy, or it could be tracheopexy or aeropexy if it's more severe cases. Even more severe cases can depend on endoluminal stent or external stent. However, a lot of these applications have significant complication rate, including stent migration, granulation tissue, and that can cause significant amount of morbidity. There's a study that says there's a up to 20% mortality rate on some of these stent placements in severe cases. A comparison of these treatment modalities shows that there's a significant risk profile for a lot of these applications. And we talked about how internal stent and external stent can have significant complications. 3D printing became popular in the application this as popularized by University of Michigan. They used a 3D model of the patient's trachea based on CT scan, and they engineer a splint based on the patient's trachea size, and then tested the splint of its engineering properties, make sure it can withstand the designed pressure loads, and then this is applied to the trachea externally with sutures. They have a publication of more than 20 patients that have successfully been applied using this treatment, and there's only one mortality in that 20 plus patients. In terms of their complication rate, it's comparable to intraluminal stent and other surgical options. In fact, there's no erosion risk, and granulation tissue is not a significant concern in this patient population. So that technology has been attempted on a very rare disease of tracheal agenesis, which has an incidence of 1 in 100,000 live births. There's less than 150 cases reported. However, number of survivors is very few. There's a total of 7 successful survivors, mostly in the Japanese population. And of all those survivors, they all require external splints. And typically, it's the PTFE grafts that have been used in those cases. This is a list of the previous successful attempts, and as you can see, PTFE is a very popular one. These survivors, the oldest survivor right now would be 7 years of age. At the time of publication, the oldest survivor is 4. The only survivor in the North America is at the Wisconsin group. They published a case report in 2016 of a survivor using PTFE splint after tracheoplasty. We have a patient born a few years ago at Penn State where we encountered this problem, and after we did a value analysis using the pros and cons approach and looking at the benefit of different solutions, we surmised that 3D printing for this pathology would be a very reasonable approach. The benefit is using a bioresorbable material. It allows the patient to minimize the infection risk, as well as being able to use other modalities to treat it after a patient grows to a larger size. This is a pre-printing that we use 3D printing on, and this is a video demonstrating how the procedure was done. The tracheoplasty was first done to connect the airway using esophagus to the native tracheal airway, and then the splint was applied externally. This patient is currently surviving at 4 years of age and doing well. So just to summarize, similar to the other 3D applications, the use of 3D printing in airway involves taking the CT scan, segment the images, and digitally design the splint, test it of its engineering properties, and then sterilize it using ethylene oxide and then implant it in the patient. This does require a regular process using expedited utility EUA protocol under FDA, and the fabrication has to be done at a FDA certified facility. And these are the references.
Okay, I'm sorry? Does anybody have any questions? No, we don't have time, okay. Summarize of the esophagus one? Okay. I guess we're going to hold on the last presentation as we are just about out of time. I actually don't have my timing on here. The last presentation really did focus upon 3D engineering of the esophagus, similar to how we were doing it in the lab. If anybody wants any information on that, please don't hesitate to talk to Joanne Walker or to myself. I'll be happy to show you some of the sides of that. This should wrap up our session for our 3D bioprinting. Thank you, everybody, for coming.
Thanks everyone for joining, and please remember to go to the exhibit hall for a poster viewing and can enjoy some wine and snacks. The wine and cheese reception is generously sponsored by Medtronic. And then remember that the welcome reception has moved indoors. It starts at 6:30, and please find your reunion tables if your group has sponsored one. Thanks again, everyone.